Hi everyone, welcome to our series of e-learning. Since due to the COVID-19 outbreak, we will conduct our classes online. That's it. Before we start this class, as a reminder to all our Phase 1 MMATs, please be safe when you see your patients. Wear your PPE, keep yourself safe, keep your family safe, and um, hopefully we will get through this together. All right, so let's start the class. Okay, so this is a KFQ question where you have 10 minutes to answer. You have 10 minutes to answer one question. Okay, so let's start with this question first. A 50-year-old security guard presented with single gunshot wound to his right chest. His vitals were BP 140 over 80 millimeters mercury, heart rate was 105 per minute, respiratory rate of 35 per minute, labored breathing, and SpO2 86% under room air. On examination, there was an entrance wound at the anterior upper right chest with bubbling sound. Lung auscultation revealed markedly reduced air entry on the right lung. The trachea was not displaced. So don't immediately answer. You will need to slow down, highlight important points in this question before you proceed to the next question. So please pause, look at the important points, and we move to the next part of the question. Okay, so state your full diagnosis, 2 marks. Please pause and answer this first. Okay, once you've answered, let's go through your answer. The full diagnosis here is because once there is a wound and it is an open sucking chest wound, there is air that is entering through the wound and it's being trapped in the pleura. So in this case, we say this is a pneumothorax because of air trapped in the pleura, and it is open because of the open sucking chest wound. So this is a open pneumothorax. But that is not the full diagnosis, because when we say we want the full diagnosis, especially when it's 2 marks, means that it is definitely a little bit longer than just the initial diagnosis. You need to not just say the diagnosis, but the state of the patient that is in. What is his current state? So you must mention that this is open pneumothorax with respiratory distress or hypoxia due to the increased respiratory rate and also due to the reduced SpO2. Okay. If you answer tension pneumothorax, it is wrong, because this is open pneumothorax can lead to tension pneumothorax, but in this case, this is not tension pneumothorax yet, because the blood pressure is still okay, and the second thing is the trachea is not deviated. Okay, so because of that, the accepted answer for this question will be open pneumothorax with respiratory distress or hypoxia. Okay, so the next selection menu will be select 4 pathophysiological process of the above condition. So basically, they want you to select the pathophysiological process of open pneumothorax. Okay, open pneumothorax. So let's go to the selection menu. Okay, so this is the selection menu. So you have to choose 4 answers. Please pause the video and answer the questions. Select the answers now. Okay, so now let's go through the selection. You have to answer 4. You cannot answer more than 4. If you answer more than 4, you will get 0 marks. Okay, you can answer less but not more. Okay, so let's go through the answers. The first one is air entrance through the chest wound, which is correct, because once there is an open sucking chest wound, the wound is 2/3 of the diameter of your trachea or your little finger. What happens is that air will prefer to enter through the wound, and it does not exit, and the air gets trapped, okay, within your pleural cavity. So air entrance to the chest wound is correct. Next, air entrapment in the chest cavity. This is false, because the air is not entrapped in the chest cavity. It is entrapped in the pleura. So please read the question properly, because sometimes you may get trapped and may answer wrongly because of being careless and you didn't really read the statement properly. Okay, air trapping in the alveoli is false. This is more a description of COPD. Bleb rupture. Okay, bleb is basically smaller bullae. Bleb rupture is more talking about COPD patients. Okay, buildup of air in the pleural space. Okay, this is correct. All right, as I mentioned just now, air is entering through the open sucking chest wound. There is air entering, and the air is being trapped in the pleural space. Okay. Next, you have diaphragmatic injury, all right, which is false, because diaphragmatic injury usually causes pneumoperitoneum, all right. It does not cause open pneumothorax. Okay. Disruption of the tracheobronchial tree is false, because disruption of the tracheobronchial tree is basically tracheobronchial dissociation, which is one of the life-threatening diagnoses that you have to look for in your ATLS. But it does not explain open pneumothorax. Okay. Remember that your 4 selection of questions has to describe open pneumothorax in hypoxia or causing hypoxia or respiratory distress. Okay. Equilibration of the intrathoracic and the atmospheric pressure, correct. Because what happens is that when there is air trapped in the pleural cavity, the intrathoracic pressure increases. Then there's loss of this negative pressure that is needed. Why? Because when there's negative intrathoracic pressure, when the atmospheric pressure is higher than the intrathoracic pressure, air can enter into the lungs. But once there's air trapped within the pleural space, the difference in this pressure is lost. And when the pressure equalizes between the atmospheric pressure and your intrathoracic pressure, air cannot come in. Hence why the patient starts having hypoxia and increased respiratory rate. At the same time, although this patient does not have tension pneumothorax, but I just want to explain the pathophysiology, where the air builds up so much within the pleural space where it actually starts compressing on the mediastinal structures. Then what happens is that it compresses the superior and the inferior vena cava, and blood cannot return into the heart. And this will cause obstructive shock. So in this case, patient has not developed tension pneumothorax yet, but patient has already have trapping of air within the pleura and loss of the difference in the atmospheric pressure and the intrathoracic pressure. Okay. The next one is increased chest wall compliance, which is false because this explains COPD. All right. Increased dead space is also false because increased dead space happens in more like COPD or pulmonary embolism. Okay. Increased intrapleural pressure is correct. Okay, as I mentioned just now, air goes into the pleura, air gets trapped, increased pressure, loss of the difference in pressure, and this causes air unable to come into the air is unable to enter. Okay, increased shear forces of lung is false because this happens more in patients who are ventilated. All right. So the next question is select 4 appropriate management for the above condition, 4 marks. Okay. So this is the selection menu. Please choose 4 from this selection menu. Okay, we pause the video and we will resume after you have answered. Okay, now the first answer is 100% oxygen via non-rebreather mask. Okay, when you talk about management for this patient, you are talking about management of open pneumothorax. Okay, open pneumothorax with respiratory distress or hypoxia. When you talk about management of this patient, you are actually referring to your primary management, which is your ATLS, okay, advanced trauma life support management. Okay, so some of the management here may seem to be correct, but it has to be more of a life-saving management, how to treat the life-threatening injury that is in front of us. Okay, so let's go through one by one the selection menu. Okay, 100% oxygen via non-rebreather mask is correct because you want to address the major problem here, which is hypoxia and also respiratory distress. So you want to increase the oxygen of this patient. So yes, 100% oxygen via non-rebreather mask is a correct immediate management. Blood transfusion, not related because patient is not having any blood loss. All right. Chest drain. Yes, this is a definitive management for open pneumothorax. We need to put a chest drain so that the air can be drained out and does not cause the air to accumulate and cause pressure to the mediastinal structures. Okay. Chest radiograph and CT thorax is definitely not indicated in this patient. Why? Because the treatment comes from a clinical diagnosis. Open pneumothorax is a clinical diagnosis where you see and you treat. You do not wait for a chest x-ray to say that there's pneumothorax before you treat. Okay? Because if you delay and do a chest x-ray first, patient may develop tension pneumothorax and the patient may die. So you need to come up with a decision as per your ATLS, come up with a decision that this patient has open pneumothorax, immediately leading to tension pneumothorax, you're worried about that, immediately you insert a chest drain and you do the decision without your chest radiograph or CT thorax. Okay. Endotracheal intubation is definitely not indicated. Okay. Endotracheal intubation because although patient is having a low SpO2 and increased respiratory rate, but in open pneumothorax, we do our measures first. Okay, we intervene and do our life-saving measures first, and then we reassess the patient. If the patient does not improve, then we have to consider intubating the patient, but not at this point. Extended fast, yes, extended fast is definitely indicated, because when you do a fast scan, focused abdominal sonography in trauma, you also do extended where we look at the pleura. Okay, look at the lungs, look at the pleura. In open pneumothorax or pneumothorax, what happens is that there's loss of the A lines, and there's also the absence of the lung sliding. Okay, lung sliding is also absent, which tells you that this patient could be having pneumothorax. Intravenous ceftriaxone, definitely not part of your immediate management. It is a management that you would like to consider later. Intravenous morphine, yes, also important, pain management. But at this particular point, I will definitely, yes, I will put morphine in my list of management, but definitely life-saving in that particular moment is not IV morphine, all right? It will come a little bit later. Then intravenous ringer lactate, also important. Yes, you want to start the patient on fluids, but it is not the life-saving management that we want to do currently. Needle thoracosynthesis is definitely out of the question, because this patient does not have tension pneumothorax, as I said before, because the blood pressure is high. The blood pressure is normal, and the trachea is not deviated. So needle thoracosynthesis is not the answer. Okay. Occlusive dressing, yes, you need to do occlusive dressing for open pneumothorax, because you want to create a one-way valve where air can leave the wound, but air cannot enter the wound. How do you do that? You put a non-adhesive material, such as a plastic, over the wound. Okay, you put it over the wound, and you want to tape 3 sides. Okay, you tape it 3 sides, you tape it 3 sides. Okay, all right, and leave one side open so that the air can flow out from there, but it cannot enter. Okay, so you tape 3 sides. Okay, make sure this material is a non-adhesive material such as plastic, so air can leave but air cannot enter. Why this is important? Because why we don't just close the wound, okay, and cover it totally, is because then air cannot leave. If once air cannot leave, then air will the accumulation of air will start compressing of the mediastinal structure and may lead to tension pneumothorax. So 3-sided occlusive dressing is a must whenever you see a patient has a open sucking chest wound. Okay. Pericardial synthesis is definitely not indicated here, because patient does not have the back striate. Back striate for cardiac tamponade needs hypotension. Patient also needs to have muffled heart sounds and also increased JVP. Okay. The next part, the next answer is also false, which is prepare for pleurodiscs. Pleurodiscs is where you stick both of the pleural layers together, the visceral pleura and the parietal pleura, you stick it together and obliterate the space. This management is usually done for patients with lung carcinoma, where they have chronic pleural effusion, and in order to stop this chronic pleural effusion, we just seal the pleural layers together so that patient will not have this problem. So definitely not indicated here. All right. Thoracotomy, of course, we don't do thoracotomy. Opening up the thorax is not needed for this open pneumothorax. And wound suturing is definitely can't be done. You suture the wound, you're going to cause air to be trapped inside. And this could be a fatal error. What do you mean by fatal error? When you answer a question, a statement which can actually cause further deterioration to the patient, or is a dangerous management, you may actually get 0 for the whole question. Okay, although you have answered 3 correct and 1 wrong, but if that 1 wrong happens to be wound suturing, which is actually a management that can actually cause patient to deteriorate, you may get 0 for the whole question. That is why don't simply answer. If you only know that many answers, answer that much. Okay, not necessarily you have to answer 4. What is needed, the exact number that's needed all the time, because sometimes in trying to do that, you may actually answer a fatal error and cause you to not get any marks for the particular question. All right. Okay, so with that, we conclude today's KFQ. We will continue tomorrow with another KFQ. I will try to upload 1 video per day for questions for you all to go through. Okay, so I hope this is helpful. Please stay safe, guys. Let's get through this pandemic together, and hopefully all of us will be okay at the end of this. For the time being, don't worry. We will continue our classes via our e-learning classes. All right. Take care. Bye. Take care, everyone. Bye. See you all. Okay. Bye.